Okay, I think you just learned that I started in 1994, actually, with colleagues, the first national adult ADHD clinic in the UK, and I set up the psychology service there. Before that, I was working with doing research with adolescents, working with Professor Eric Taylor. He was my PhD supervisor. And before that, in my training, I did a lot of work with children at Great Ormond Street Hospital, many of whom had ADHD, and actually worked with David Skuse there in the Institute for Child Health, and learnt about ADHD in children, younger children, and how it presents. So in a way, my career has kind of grown up with the children. So children to adolescents to adulthood. And then I moved back to adolescents, and then back to children, and now I sort of I cover the whole gambit. And I think that's led me to believe how important it is that we see ADHD as a lifespan condition. It's not a condition that you have as a child that just disappears in a puff of magic when you reach the age of 16. Some people will not have symptoms as they get older, as you know, but they have what we call a hangover of ADHD, and I will talk a little more about that later. In the UK, what we're grappling with now, and have been for a while, is the issue of transition. And that's why I was asked to talk about this. I wrote a paper, an article that's published in open access in BMC Psychiatry called Avoiding the Twilight Zone, because it's at this stage that we're losing a lot of young people from our services, and they're not transitioning from children's services to adult services. I'm one of the NICE guideline development members. I'm part of the group that developed the NICE guidelines. They were published in 2009. And we started to think about this then. I think things are improving, but not nearly as much as it needs to. So I'm going to be talking to you today about that. This evening, I'm talking more about, we called it making ADHD, making the invisible visible, which is a lot more about the work that we did that was submitted to the Brussels Parliament. So, to look at what we know about ADHD, as I said, it's a lifespan approach, and we have to view it this way. So, the symptoms, as you know, are inattention, impulsivity, hyperactivity. And you see I've added another symptom here, emotional lability. And people working with adults and indeed adolescents, we see emotional lability as the fourth symptom of ADHD, because it increasingly becomes more and more marked in adolescence and towards adulthood. And it's something that we have to deal with. They have to learn strategies to deal with it, and it causes a lot of difficulties and distress to themselves, to the individual, but also to those working with them, their families, and in what they aim to do in their occupations. Population surveys estimate around 5% of children have ADHD, and around half, about 2.5% of adults have ADHD. Steve Faraoni conducted a meta-analysis of all the follow-up studies that had been conducted, and what he found was actually 15% will retain a full diagnosis of ADHD by the age of 25. But he also found a further 50% who are in partial remission, but that 50% still have persistence of symptoms that are associated with impairment. And this is really important because, you know, even if you have some symptoms that cause impairment, you have impairment. in something that may be expressed functionally in what you're trying to do or achieve in your life. There are high rates of comorbidity. It's comorbid in childhood, mostly with conduct disorder, anxiety. Also, as we know, autistic spectrum disorders now, DSM-5 recognizes that comorbidity. And mood plays a very important role, as I alluded to earlier, and in adulthood, personality disorder. When I'm talking about young people with ADHD who are transitioning from one service to another, we often focus on the service aspects, and I think what gets lost is that we're talking about people, and we're talking about young people and their experiences, and we forget about the individual, the service user. These are young people who are also in transition in their lives. Can you remember what it was like when you left school, then had to go on? You're making important career decisions, your school friends, all your relationships change. I have a teenage daughter. She's an absolute nightmare. Many people, I'm sure, in the audience will know what I'm talking about if you've had teenage daughters or sons or have one right now. So it's a difficult time for them at the best of times. Then these young people also have ADHD, and they're transitioning from one service to another. You'll see later I have a website where I have rewrote with some colleagues a book that's freely available on there called ADHD in Adolescents. And when we were putting this together, we talked to young people with ADHD, and we interviewed them. They gave us permission to interview them. And they described to us what it feels like to have ADHD. And we really do need to listen to this, because these are the young people who we need to provide a service for. So I've got a couple of answers here, a couple of videos of young people describing what it's like to have ADHD. And the interviewer starts with the question, so can you tell me what it's like having ADHD? If anyone's recorded, please do not record this, because I have permission to show you in presentations or to use it in my training, but we do not have permission for these young people to go on the internet or to be recorded on any device and shared, clearly, because they're patients. What I find remarkable is that the first question, the answer isn't, well, I'm inattentive. The answer is, I can't control myself. And it's my out of control. It's not everybody else's out of control. This is my out of control. People don't understand what it's like for me. And then this guy has to explain it by saying, well, it's like not having, things don't go in my head. It's like having chewing gum on my head, and it's not sticky. Things are not getting in there. And big paragraphs scare me. Can you imagine what that feels like? And that's their description of what it feels like to have ADHD. Ooh. So, developmentally, what does it mean to have ADHD? And I think, as I said, it's a lifespan condition, and and it starts when they're quite young. Even we have reports from preschool. I've seen, and I'm sure many of you have seen preschool reports from even young children who we discovered later had ADHD, have been told not to come back to a kindergarten or a school, a preschool. What do you call them? A creche, somewhere where parents work, where you put young children. Even very young, you hear stories that they couldn't cope with the child there, and they've been asked, the child's aggressive or runs around too much, and they can't cope. So some of this behavioural disturbance, sometimes, although probably at this stage we don't know it's ADHD, looking back, you can see that there are signs very early on. And then I think what happens is as they go towards adulthood, things accumulate. It's a cumulative thing of baggage. And that baggage they're pulling gets heavier and heavier and heavier as they walk this pathway. So at school, you start to have the academic problems. Many are excluded from school. They may not get on with their peers. Peer rejection's common. They may be the last to be picked. But I hate that when you see schools when people have to pick who's going to be in your team. There's always the poor kid at the end who's not picked. There's comorbidity, and then as they get older, it all gets a bit worse. They might get socially isolated. They might find alternative friends in a bad crowd. Smoking, drugs, these kind of things might start up here, so there's more baggage coming along. And then college, maybe they're not doing so well as their siblings. Their brother goes to university, they go to college, feel a big letdown to the family, feel that their parents are disappointed in them. They're trying maybe lots and lots of different jobs. Often at this age, they're starting to work part-time, even while they're studying. Some are not studying at all. I remember an adolescent girl that I saw who had a part-time job over Christmas. Everyone was delighted she'd got a part-time job. But she was in a retail store, and they put her on customer services because she was very personable. She had all the, chit-chat. They put her in customer services. So what happens after Christmas on customer services? Everyone's bringing back all their presents and things that they don't want. She's got a great long queue. People saying they don't want it, saying why they don't like it. She completely lost her temper with everyone and told them all to F off. Lost her job. So, they're having to deal with all sorts of responsibilities and additional things. Poor self-efficacy and low self-esteem kicks in, maybe alcohol and substance misuse. Injury and accidents starting to kick in. Have any of you heard in the last week there's been a fantastic, I'm going to present the data this evening, there's been a fantastic paper that's published in the Lancet that Søren Dalsgaard, my colleague, presented from the Danish National Registry that's reporting that untreated ADHD, the morbidity is 2.5 times greater than people without ADHD. So you die. It's a deadly disorder. And why? Most of it is related to accidental injuries and fatalities. So there's a lot going on here. And then they hit adulthood, and then you've got, more marriage, and got more other different types of relationships developing. So it's like as they grow up, this baggage that they're carrying along with them increases, and as that increases, the self-esteem decreases, and self-efficacy too. We know when we look at the academic outcomes that there was a study done in the States that both boys and girls have reading problems, around 50% compared to people without ADHD, significantly greater. Even more than about 50% for written language problems compared to those without ADHD. Around 39% of children will be excluded from school, and of those excluded from school, 11% will be permanently excluded from school. And that's their UK data. So what happens, to them, to those who are out of the educational system and into some kind of special remedial or different type of school? I don't have the data for the non-ADHD. But was part, I suppose, of an expert group that looked at one called it was originally called the Better Futures Group, but that then became the UK ADHD Partnership, where we presented data to the Brussels Parliament. And what we want to do, what we aim to do, is to say at what point should you intervene earlier in the process to change these pathways into adulthood. And what we felt, the experts met, and what we felt is that the signs are there. These people are not growing up as having difficult adulthoods. The signs are there very early on. It's signposted. but we're missing the signs. And we felt as a group that this is where the biggest signpost is, where we can intervene. Not at the first school exclusion, because at first school exclusion, children can make mistakes, children can learn from their mistakes. But at second school exclusion, teachers and families at that stage should start to think, is there something else going on here that we need to look at a bit more? And that was where we recommended the first intervention is done. Occupationally, they're struggling in terms of their occupation. We looked at data for following up from our clinical patients at the Maudsley Clinic, and what we were finding there was actually people with ADHD were employed, either unemployed or employed in lots of different types of employment. So they were trying lots of different things. Rather than a career path, they had high turnover of jobs, but also lots of different types of jobs where they just can't settle into what they're going to do. When we looked at it in more detail, we found that 44% of our sample were unemployed, and 13% were students, if they had ADHD. Those who were in partial remission, so below sub-threshold, 40% were unemployed, and 21% were students. So about the same, even as if some of your symptoms are starting to dissipate. For those who we classified as in full remission, these were the people that we assessed who we felt had ADHD as a child, but who were no longer ADHD. 22% of them were unemployed, but 44% were students. And if we compare this to our control data, 3% were unemployed and 30% were students. So in remission, this seems to be, for that group who had ADHD as children, who probably have got the academic impairments, academic problems, not so qualified, as they get older, as their symptoms remit, they have more opportunity to get into the workforce. Or it seems that there might be a bit of a catch-up here with them entering further education, okay, to try to gain qualifications for, perhaps to recompense for the missed opportunities that they'd had when they were younger. But still, 22% unemployed compared to 3% of controls. I show you this slide because I had a patient for quite a while who I was working with, and one of his big problems, a young man, was that he was trying to get a job. So I was doing a lot of work with him to help him to get a job, and because what he was doing is he would get interviews. So he'd get interviewed, but he'd never get offered the job. So I said to him, I thought there's something going on here, there's something wrong here. So I said, do you ever get feedback from your interviews? And he said, no. I said, well, ask them for feedback. Let's see what information is coming back. So he started to do this. So he arrived for his session, waving this email, and said, I've got feedback, Susie, I've got this feedback. I said, okay, let's look at this. So we looked at the feedback, and it said, well, your CV was well presented and it was clear. So he got the interview. You presented well, you looked right, you looked good, but you arrived 15 minutes late, okay, all right, maybe a bit late, but it's not still, not preferable, but, things happen. So we appreciate that you experienced delays to your journey, but we were not impressed that you arrived holding a Starbucks coffee. You drank it during the course of the interview and left behind the empty beaker. They said you gave long-winded and tangential responses to questions, often revealing unnecessarily irrelevant and personal information. So like that other young man said, he goes off track and he'd start, talking about holidays and all sorts of other things, and giving examples that were just not relevant, because he couldn't, like this young man, if you think about the young men I show, they couldn't hold the question in their head, and one of them was giving different kind of answers. So that's what happens in an interview situation. They said you seemed argumentative and confrontational at times. That he disagreed with the perspective. They got into some disagreement about the method of something, about how you would approach a job. He worked in IT and computers, and they got into a disagreement about, and he was disagreeing with the panel about something that they wanted. It said, no, you've got this all wrong. This isn't the way to do this. You need to use this method because it's a much better method for doing this, and I can show you how to do it. And then they said, in future interviews, we suggest you avoid chewing gum, you avoid offering gum to the interviewers, you avoid showing photos of your dog, and you avoid using the F word. The other thing with this young man, and actually he was very nice. There was an awful lot, but it was very sad, because he'd say to me, people find me weird. I'm weird. They just find me weird. And he didn't quite get about how to change it, and he really had no insight about how we should do this. And the other thing he'd do is, I remember him coming in once, and I opened the door, and he was straight in the door, and he was in my face, and he'd prepared on the train everything he wanted to talk about, and he had all his papers, and he'd written notes, and he wanted me to see this and read it, and he was right in my face, and he was saying, here you are, I want you to do this, and I want you to do that, because it's been translated, so I probably can't do this as fast as he did it. But I almost felt like I was under attack, because he was so close, and he was so rapidly addressing me. And he was giving me these papers, and he said, right, you do that, and I'm going to go to the toilet, and then I'll come back and we'll talk about it. And I was left feeling like a whirlwind had come through the door. So what I did, and if you imagine that in an interview situation, as soon as they come in. So what I did was, when he came out of the toilet, I said, what we're going to do is we're going to practice your entrances. So I put him back. So I had him, we spent almost the whole session role-playing, because role-play is very important with them to learn how to do things. Role-playing, knocking on the door, pausing, waiting for me to open the door, that few seconds before he came in. It's just those few, just doing that, going in and out. And then he got it right. And he was so pleased. And on his way home, he was on the train back, and I got a text saying, thank you for today's session, Susie. I found it really helpful. How were my goodbyes? But I guess why I'm telling you this is because there are things that we do that are very natural for us, but we need to really, and it's quite basic things often, I find, that need to be taught, and you can teach these skills. It's just skills that they haven't developed for one reason or another. Right, clinical outcomes. What's happening clinically is that if you look at 7 years, this is the pale colour, to 17, if you've got ADHD, you can see, and as a control, your symptoms improve. But relative, so sometimes, I think this is why it was believed that people don't have ADHD in adulthood. It's because if you see the ADHD at age 17 is about the same as a control kind of at age 7. But things get better for the people without ADHD as well. So they're still relatively impaired compared to their peers. Comorbidity, this was from the MTA. Comorbidity is the rule rather than the exception. So we have ADHD, we have an awful lot of oppositional defiant disorder going on, in this yellow circle, we have a lot of conduct disorder going on. They've got anxiety disorder, mood disorders. Actually, I think that depending on the age, the MTA group were quite a young group. As they get older, I think that circle is getting bigger and bigger. And tics, Tourette's. So rarely are you dealing with just ADHD. And of course, the MTA study was done before DSM-5, so of course you haven't got autistic spectrum disorder as well on there, but we know that that also is a comorbid problem. Some colleagues of mine, Skiro et al., they looked at, to think about mood. Some colleagues of mine at the Maudsley, Skiro et al. And Philip Asherson, they specifically looked at mood symptoms in 27-year-olds. And this is if you don't have ADHD, and this is if you do have ADHD. And by 27, this is like significantly greater symptoms of depression, dysthymia, elation, irritability, changeability, and volatility. There's a lot of interest now about mood and what's going on with mood here and this mood instability. And I'm not talking about bipolar disorder. I'm talking about rapid mood problems, not being able to regulate or control your mood, moving rapidly from one mood state to another. And what I think they do is the same as everybody else in the course of a day, but it's more extreme. ADHD is a disorder of extremes. And this is the feeling, this is the out of control. This is the pulling right this way and then pulling right that way. So you've got your ADHD, you've got the conduct disorder, antisocial personality disorder, addiction, all this bad stuff that it may lead you to in your path to adulthood. And you've got a lot of environmental risks that are mediating that, but also this mood instability that's appearing and is increasing along that pathway. Well, I've done a lot of, I work in forensic services, and when I worked at the Maudsley, I was very interested as to what was happening to some of our clients. I was following them up, and they'd disappear. Couldn't contact them. And then they'd reappear about 2 years later, or a year later, and I'd say, well, where have you been? So I've been in prison. And this was in the 90s, so I started to get interested in this, started to routinely ask about offending histories. But all the studies started coming out, giving all sorts of rates, and I wanted to get a real good handle on what the rates were in prisons for people with ADHD. And so I did a meta-analysis of international studies that was published in January 2015. And this is available in open access in psychological medicine. When I say open access, it just means you just go on and you can put my name in, and you'll find it, and you can download the paper. And if we take people who are diagnosed using a clinical diagnosis, a full, proper clinical diagnosis, there were 30% of youth offenders with ADHD. That's a 5-fold increase compared to the population rate with ADHD. And 26% of adults. That's 10 times more than the population rate for ADHD. More males than females, but there was no significant difference when we looked at this. And there was also, they had a younger age of conviction, and there was little treatment reported. And I think what's happening in the prisons is it's the researchers who are going in and identifying and doing it. And certainly with all the prison research that I've done, actually, and the forensic mental health research that I've done, hardly any of them have already received a diagnosis of ADHD. And that is shocking. It's inexcusable. Actually just yesterday, we had another meta-analysis accepted in psychological medicine that will also be in open access. And there we looked at comorbidity in the prisoners. And what we found was that the youths, that the youth group, most of the problems were mood related. And when you get to the adult group in the adult prison, they've got far more a broader variety of mental health problems, anxiety, depression, much more personality disorder. So it's kind of supporting what I was saying earlier, that these things, there's a cumulative effect of difficulties as they grow up. In the UK, the first line treatment for treating for ADHD is psychological treatment if you're a child, but if you've got severe symptoms, it's medication, and it's stimulant medication. And if you're an adult, the first line treatment is stimulant medication. Some colleagues of mine, the McCarthy et al., they looked at the GP registry. They looked at the GP database for a 5-year period between 2001 and 2005 to see what are the prescribing patterns in the UK. And there were 3 million active ADHD, 3 million active patients on there, and with ADHD. And what they found, firstly, was that the ratio of males to females receiving prescriptions was almost 7-to-1, which is much higher than the 4-to-1 gender ratio for ADHD, indicating that males are much more likely to be identified and treated with medication than females. And I think we know that. We see that more males than females are being diagnosed. But what was interesting is that they're more likely to receive medication, much more likely to receive medication in the UK. What we also found was that prescribing patterns decreased during adolescence, and no patients were receiving medication by the age of 21. And that's these coloured bars. The years you can see, so you can see that over the years medications increase the use of medication, but as they get older, it decreases to the age of 21, and here you've almost got nobody taking any medication at all. Well, okay. This dotted line, though, represents the Faraoni meta-analysis that showed that 2/3 are retaining symptoms that are associated with impairment. Okay? This cannot possibly be spontaneous remission. It's not possible. What about all the others who still have impairment, who were on medication and who are all stopping by the age of 21? What's happening to them? Where are they going? This is what's happening. This is what it feels like. It's depressing. This is what it feels like, that the long-term outcome of childhood ADHD is they get to a certain age and it's like falling off a cliff. We need to stop that. Why is it happening? Well, I think there's lots of reasons. I think they're leaving school. I know adolescents, they leave school and they think they're not studying anymore, so they don't need it. Not so much need. I think there's lower expectation from parents when they're older and teachers that treatment is still needed. Maybe, maybe that's reinforced perhaps by the educational establishments, by parents. I think that they develop coping strategies. They're teenagers, they're starting to do things themselves, they're learning other strategies. These strategies may not be adaptive. It may be that they've started to smoke cannabis 3 times a week, 4 times a week. Maybe that they're drinking alcohol. So I'm not saying that they're adaptive strategies, but hopefully some of them may be, though. I think some of them are moving to less demanding environments or employment. So at school, you're having to study, you're having to work, do homework. And sometimes they're moving to more physical environments, like, I don't know, like skydiving with somebody, might be a bit risky actually, but, but it's more stimulating, more environments where they don't, where they don't have to study or concentrate so much. Actually, skydiving is a really bad example, so strike that one. But perhaps, people on building sites, like labouring assistants. Okay, that's quite common. I think they have to leave the service. They're leaving the people they know, they're leaving a child's service, and they're resistant to starting again. You've got to start all over again in the UK with a new service. And that's hard. People don't like change at the best of times. It's hard for an adult to do that, and we're expecting them to do that. They have autonomy. Their parents are not taking them to appointments so much now. They're taking responsibility for attending appointments. They're not being taken, and they forget to attend appointments. They just forget that the memories are terrible, and they mean to do it, and or they're late, and they've missed the appointment, and so it just all fizzles out. They're oppositional, and they push the boundaries. Adolescents, you say black, they'll say white, particularly if you're mum. You say you like this, you should do this, they'll say I won't, I'm not going to. It's just, they push the boundary. They don't want to, they're not going to do necessarily they're not going to take advice from the people perhaps who are best placed to give them advice. They're probably also listening to other people. They're taking note of what some of their peers are saying, and that might be good advice, but it might not be good advice. There's definitely a perceived stigma in the UK because many of these kids are moving from pediatrics to adolescent mental health services. I think it's not so bad for those who are in child adolescent psychiatric services moving to adult mental health services, because they're already in a mental health service. But for those moving from pediatric services to adult mental health services are moving into a mental health service. And I remember working with a young girl about that, who just refused flatly to engage with the adult mental health services. And it was all about stigma. And she looked at me as if I was mad. She said, "You're the mad one. Why would I want to go to see these people? I'm not mad." She said, "Are you mad, thinking I'm going to do that?" And she went, I'll never forget it, because she just sort of said to me, "Duh, mental health services. I'm not mental. Duh." She had she's feisty. She had lots of attitude. And, this is an issue. I think as well, though, that in the UK, we don't have the services for them to go to. We have a saying, all dressed up and know where to go. And it's like people can be ready and they can be all geared up, but you've got to have the services set up for them to attend them. Some studies have been done on this, and only 20% of pediatricians in the UK believed that they could access adult ADHD services. That's 80% of them believed that this wasn't on their radar to access. Adult psychiatric services were the common referral pathway, but the pediatricians felt that the adult forensic services were not well equipped, or they were unwilling to take ADHD patients. Now, you could say that's wrong, but actually that wasn't just their perception. I think that really was what it was like when this study was done. I believe it's getting better. GPs were perceived by them as not being appropriate because they wouldn't prescribe stimulant medication. And again, I think that's changing with shared care protocols. Now, we have many more GPs who are prepared to do that. But the service, certainly in the UK, is patchy. Some areas are better than others. And of course, we have young people. They reported that young people were reluctant to see adult psychiatrists due to stigma. And I think we should bear in mind that this huge decline in service utilization that we saw, that graph that just dived down, that is occurring at a time when at an age when serious mental health problems may emerge. We know that 10% of 5 to 16-year-olds have a mental health disorder, and 98% of an older group who are accessing services have at least one problem. So most of them who are accessing services do have a problem. Mental health problems in adolescence predict mental health problems in adulthood. There's a relationship there. And of course, those who are slipping through the net, who are in this gap, are very likely, because of the lack of service input, lack of assessment, lack of monitoring, they may present later with more severe and enduring problems. Well, there's some guidance. So if we think about, well, what guidance is there? Well, the Department of Health National Service Framework for Children, Young People and Maternity Services, all about transition. It's called Getting It Right for Young People. Improving the transition of young people with long-term conditions from children's to adult mental health services. Published in 2006. Great. This is going to give us some guidance. 48-page document on how to manage transition with no mention of developmental disorders. So we've got no help, no guidance there. NICE, as I said, recommended transfer from child to adult services. And at NICE, but it was brief. It doesn't go far enough. But they said you have to have significant symptoms of ADHD or coexisting conditions that require treatment. It says that transition should be planned in advance by both those referring and those receiving. They need to get together. And that patients need to be reassessed at these stages. They need to be reassessed at school leaving age. And arrangements need to be made for a smooth transition. They said the timings of transition may vary. They recognize that it could be variable as to when is the best time in the young person's life to effect transition. But it should be completed by age 18. And during transition, they should, the CAMS, the Child Adolescent Mental Health Services, or the child services and the adult services should meet and share information. And information about the services and about what's going to happen needs to be made available to the young person. For young people aged 16 and over, we recommended that the care program approach should be used to aid transfer. The care program approach is a document that sets out a treatment plan. It's commonly used in adult services in the UK, but not in child services. And when I've talked to pediatricians, they're aware of CPA, and when I've talked to any child services in the UK about this, this is a good idea, because it sets out a planned protocol of care. And if you think what's being suggested is that this is kind of the input is put in together from the adult services and the child services with a reassessment. What do you do after transition? Well, again, a comprehensive assessment needs to be carried out, because there are problems. Because an adult assessment, adult psychiatry will do a different assessment to child psychiatry, because they've got a different checklist in their head of emerging problems. They're looking at different things. So there needs to be a comprehensive assessment done then. And that also that ADHD teams across the services should jointly develop training programs for diagnosis and management of ADHD, age-appropriate training programs. So if we think about it, then who is presenting at the adult clinics? Okay, so we've got this transition group who are presenting. These are the people who are diagnosed and treated for ADHD in childhood, and they still need treatment. These are the graduates. They're graduating from child services and moving into a different service. They may be stably maintained on medication, so they will need drug monitoring. But they also may be stably maintained on medication and have residual problems, so they probably need drug monitoring and psychological treatments. And you've got another group who may be just unstable on treatment, who need a lot more assessment. Second group you've got is the currently untreated group. You've got a group who are diagnosed in childhood but are currently untreated. This is a group that are perhaps have disengaged from services and reappear at some stage to adult services. And you also got another group, the never diagnosed group, those who've never been diagnosed, never had a diagnosis made in childhood, and they're presenting as adults for assessment and diagnosis and treatment for ADHD in adulthood for the first time. And often many of this group are coming because their children are being diagnosed, they're engaged, and they're thinking to themselves, my goodness, I recognize these symptoms. I reckon he's like me, and it's coming through from that route. But we don't have much evidence for what happens to these individuals who are falling through the care gaps. We really don't really know exactly what's going on. Part of a group, we've just got some funding from the NHS to actually follow this up and to find out, to do some research into this. We don't know what interventions might improve the process. We know they're probably needed, but we don't know what. And there's no evidence for service user and carer experiences. And that's important, as I said, because it's a risk period when lots of other things are starting to go on and other disorders are likely to emerge. Also, with those who are presenting, those with ADHD, they're all going through different stages as well. You've got a partial remission group. So they might be getting better, their symptoms might be abating, they're graduating from their ADHD, but they've got what Jessica Bramham and I call the hangover of ADHD, because they may not have all their symptoms, but they've got all this baggage that they've collected all through their life. So they're having to deal with all of that and sort their lives out. You've got a group that need monitoring and assessment to find out whether medication is still needed. With those who are growing out, where are they in their remission? Do they need additional help? Don't they need additional help? Do they need psychological support if they're coming off of medication? What are their needs if they need psychological support? Well, you've got those people from child services who are in transition. You've got a group who might need help with the transition process. You've got a group who've got a lot of comorbid problems, and we know from the What Works literature that a lot of these problems are more amenable to psychological treatment than medication. You've got the group who are getting their diagnosis for the first time in adulthood. They need to accept the diagnosis. We did a study, we interviewed patients and did a qualitative study. We interviewed the patients and we interviewed their partners to ask them what it was like to receive a diagnosis for the first time in adulthood. And what was clear is that before, and I've seen this over and over again with treating them, you actually can't even start working with structured skills, with CBT, or with any, you can't really do any of the structured stuff, the stuff that needs to be done, until they've accepted the diagnosis. They've reframed the past, they've thought back about what's brought them to this stage in their life and why, and try to get some kind of understanding and acceptance. And it's only until they've gone through that process that you can start to really work with them to help them acquire skills and coping strategies. And then you've got another group, the remitting symptom group. What do you do for them psychologically? Well, this group, if they're coming off medication, some of them feel they've lost their crutch. Okay, so they're going to need help with perhaps some bad habits, things that they need to make much more of an effort with organisation, with time management. They need to learn, these are skills, they can apply them. What do we do? Well, we want to reduce functional impairment. We need to reduce the symptoms. We need to reduce the comorbid and associated problems. And we want to improve their quality of life. Far too often, I think, that the focus is on symptom reduction. You know, who cares if somebody's 3 points lower on an ADHD scale in attention? It might show that your medication is working, but what does that really mean if it means they can't get a job? If they're walking into a job interview and telling someone to F off or showing pictures of their dog. It's, you know, it's not really important. So it's about improving quality of life. We need to be thinking about critical periods across the lifespan. This is not just about, transition is one critical period for them, but we all go through critical periods. Think of your own lives. Leaving school, college, university, changes, getting married, having children. You can divide your life up, can't you, almost into particular time points. Dare I say, divorce. You know, there are times when you can see that there are critical periods when people need support and help, especially if you have ADHD. Of course, there's individual treatment, there's also group treatment. But if you're working individually, and to a certain extent with groups, you need to make certain adaptations to the approach that you make. You're not going to approach it. They can't sit in a 50-minute session without having a break or without having some kind of interactive engagement. So you have to change your delivery style. So I've developed 3 programs. One is a group program, Rapid, for 8 to 12-year-olds. One is R1R2 for ADHD youths and adults, which is a pro-social competence training program. This was initially developed for people with who were antisocial and had ADHD, but in fact, it's been run very successfully with adults who just have ADHD and not being referred for antisocial problems, and what we call the Orange Book, which is an individual and group program for adolescents and adults. The Young Brahman program is a structured program, and it's in a book, and I think you have it. Some people are using it here and actually are using it to conduct a study, which I was delighted to hear about, and I'll hear more about this tomorrow, and I'm really looking forward to hearing about that. But the structure of it gives the background. It has a whole load of core symptoms and modules with specific treatments. It's all based on cognitive behavioral therapy for attention, memory, organization, and time management, and impulsivity, and then all these comorbid problems. Problem solving, interpersonal relationships, anxiety, frustration and anger, low mood and depression, sleep problems, and substance misuse. And when working with somebody with ADHD, bear in mind what I started with. It's a lifespan condition. Even if they don't have their symptoms, they have that baggage that's coming behind them, and they can dump some of it, but there's still expectations often as well. And what's preoccupying them the most is, what's the future? What does the future hold for me? And it's really important to include an aspect of the future in all your treatment with them towards the end. Oh, this is just the format of it. It describes the deficits, describes how to assess the problem, has a psychoeducational component, the CBT, techniques and strategies, then a summary, and then the group treatment outline. Group treatment, I think, is important because it gives an opportunity to meet people with similar problems. I suggest that when you put your groups, if you do groups, that you have a common denominator, so they're all the same age, they're all in transition, they're all students, they're all parents, they're all unemployed, because then there's some cross-fertilization of ideas and suggestions. Select the appropriate modules for the groups. Each module has a session plan for 6 sessions, but you can make that shorter or longer. And in the group sessions, it encourages you to personalise the group by selecting problems that are discussed in the starting activities for exercises. It's very interactive. And again, it's important to leave time for discussion and questions and always end with the future module. That really just shows what I just went through. The starting activities are the basis for general discussion, the psychoeducational module. You give handouts, you give information that's a bit more didactic. Then you engage in exercises, which may be done in twos or in the larger group. There's lots of role play, because it's really important to rehearse skills and strategies and obtain feedback. And then homework. No, none of them like doing homework, but you should set it, because that is where they do it, translation of skills that they acquire in the group are transferred into everyday life. We don't want people to do well just in the group session. What's the point in them being perfect in that hour with you if then they leave and do their own thing? Okay, it's really important that you make a bridge between the therapy room and everyday life experience and activity. We evaluated it, and what we did, this really shows what can be achieved actually with intense small group work. We did it for 3 days, 1 day a month. So like, I think it was the first Saturday of 1 month, then the first Saturday of month 2, and the first Saturday of month 3. And most of them were on medication. We selected the modules that we wanted to do, and we obtained qualitative feedback. And they did value meeting others and sharing experiences. We didn't have any significant difference in anxiety or depression. Large effect size, though, for knowing much more about ADHD and understanding more about ADHD. Medium effect size for increase in self-esteem, and a large effect size for an increase in self-efficacy. And that's really, I think that is really important, because that's what I want my clients to do, to leave me and believe in themselves, to believe. If they believe, if I do this, it might work, then it might. It's about believing that you can change your life and you can change things. Okay. So, I think far too often when people talk about transition, they're thinking about it as a healthcare event. Transition, it's an administrative event, and the focus is much too much on service transfer. And I know I've talked a bit about that, but as I said right at the beginning, it's so important we remember we're talking about people. People who are moving to an adult role with career decisions, responsibility, their employment, they're separating from their family, they're developing intimate relationships, and the self-concept and self-image is all too important. So I often think it's ironic that teenagers are so desperate to be different to everyone else, and yet they all dress exactly the same. So then there's developmental and healthcare. But with them, there's a healthcare shift away from the parent to the young person. So many times in adult clinics, I've had a young person come to the adult clinic and sit in front of me, and that person's never been spoken to directly before, because the conversations have always been with their parents. They've never had the parent out of the room and talking. Well, I've assessed people. The mum goes out of the room, and then I turn around and say, "Right, now tell me everything that you didn't want to say when your mum was in the room. What about drugs? What about girls? What about?" And you get slightly different stories. So we have to support them during this developmentally challenging period. When should they transition? Well, probably between 16 and 18 years old. But arbitrarily, people are doing it even up to 24 years old. And I think what's happening is that services are holding on if they're in full-time education. They're reluctant to transfer them to the mental health service for some reason, because they've had a long-term relationship with them, because they've got a positive engagement with the family. I'm not sure. Maybe this holding on is more for the therapist than for the child who's transitioning. Maybe this isn't so helpful. What are the barriers to transition? Well, it's caused by a difference in views on the diagnosis of ADHD, I think, sometimes. It's caused difference between the services, causes and treatment, a difference in service organisation and professional training between child and adult services. And that's why it's really important that these services get together to get it right. In the UK, transition policies do exist, but they differ between child agencies in key procedural details. So, it's about how are we going to get something that's organised and structured where everyone knows what they're doing when you're dealing with so many differences to start with. And service user involvement, it's so important. As I said, at age 18, mental health services are no longer obliged to involve parents, carers in treatment due to the assumed autonomy of an adult. The parents are sent out of the room. We don't talk to the parents anymore unless the child specifically says, I want my mum, dad here with me. But what does that mean? It means the families often feel left out. Carers feel distressed. They don't know, and the person with ADHD comes out and they say, well, what happened? You're still on your medication? Well, I don't know. They don't even want to talk to you or communicate. The teenagers, they don't want to at the best of times. They haven't remembered half of it either as well. So, this leads to a risk of disengagement and of disengaging with the people who are going to help and support them the most. So it's so essential, I think, that protocols emphasize service user involvement. It should be central to the process. But there aren't any protocols that tell us how we should do that, how we should prepare service users for the transition. There are no guidelines about it. And also no guidelines about what happens. How do we ensure continuity of care for those who are not accepted by adult mental health services for some reason? What happens to them? Nearly finished. So there are some good examples. There are specific transition workers. We have this in some of our services in the UK. We have specific transition services and services operating. They operate separately from child services and from adult services. They bridge the gap. We have this in the UK in some areas, and in fact, those young people I showed you the video, they were part of a transition service. We have it not only with ADHD, but, for example, early intervention in psychosis has this transition service as well. The question is whether they put in unnecessary divides. Services need to be flexible to needs and not just focus on chronological age. But the change has significant resource and training implications. When one considers, though, it has implications for resources, but when you consider that for a sizable number of young people, they're moving from the classroom to the courtroom, there's got to be a health economic analysis that will argue that we have to get this right and keep them involved in our services, if they need to be. So the pathways in the UK are commonly this one. You start with the GP, with primary care. You go to child services up here. If you're stable on medication, you come back down to here and come back and are managed by the child services. You've got a group who might drop out of treatment. They may reappear at some stage later and move up to and then represent to adult psychiatric services. Then you've got some adults who come here. They're going to the adult psychiatric services because they're coming for first-time diagnosis and treatment in adulthood. Adult psychiatric services will keep those who have a poor treatment response and have complex comorbidities. But if you're stable on treatment, here, look, you'll come back down to here and go back to the GP. In that crossover in the Venn diagram, in that little crossover, that shape there, that's your dropout rate from child to adult services. This is the ones that we need to, these are the young people that we need to try and keep in services, and this is where they're dropping out. The other model is very similar, but you have a transition service in here. And then, of course, the aim is that you don't get a dropout. Realistically, you're going to get some, but not so many. And this is a model that seems to work, but it has resource implications. So the transition period is 16 to 18, but use discretion. You need joint meetings between child and adult services. We need to be talking to patients, not just the parents. You need to prepare the parents to let go. They need to be involved too, especially with child services. And so essential is that everyone gets written information and that this is developed across services, not just by one service or the other. So it's meaningful and useful. We need to be engaging adolescents. We need to be informing them about the risks of disengagement and the need to continue medication and combined treatment, multimodal treatment, combining psychological as well if that's necessary. In fact, we need to be providing that as well if they need that additional support during the transition process. It's so important that we engage them. They need to know the risks. We need to be telling them the truth. We need to be talking to them about their future. They've got really important decisions to make that will influence their future. I often think that, these decisions are being made when you're 17 or 18 years old. It's very young, isn't it, to be making whole decisions that will affect your whole future. And another essential thing that will change as they get older is they need strategies about disclosure and to reduce stigma. The question I'm asked the most from all of my adolescents and adults is, do we tell or don't we? When we apply for a job, do I tick the box to say, I have a disability, it's called ADHD? What do we do? Is this going to cause stigma? And it's one of the hottest discussions in any group that we run. So, this is the publication, Avoiding the Twilight Zone. As I said, you can download it. BMC Psychiatry, we extended the NICE guidelines with about service transition. I'm working on another one at the moment. UCAN had an expert group a while back, and we're doing a publication to bring this up to date, so that will be coming soon. That will also be open access. I can't give you more details about what or when yet. This is the website, and you can get on here, and it has loads and loads of resources. And here is ADHD in adolescents, whole resource that you can view online or you can download the PDF. There's also lots of other resources on there on the left, and we have lots more coming, including I don't think it's on at the moment. The ADHD lifespan functioning interview, the ALFI, which is an interview that was developed for conducting assessments. Yeah, here it is. Here it is. I didn't expect you to read that small thing. www.psychology-services.uk.com. And we have loads more coming. And I really want to put many resources, free resources as I can to help people on there. So these are many of my colleagues that have helped me with this, and I'm sorry I ran a bit over, but thank you very much for sitting so still and staying so attentive. Thank you.